Olá, boa noite a todos. Eu acho que a gente está ao vivo. Boa noite a todos. É um prazer tê-los novamente aqui com a gente em mais uma live do Câncer de Mama Brasil. Dessa vez teremos a honra de ter o professor Henrique Kuerer, do MD Anderson, compartilhando um pouco do seu conhecimento com a gente. Ele vai falar sobre um tema extremamente pertinente para nós cirurgiões, que seria omitir a cirurgia mamária em casos de alguns pacientes terem extrema boa resposta à quimioterapia neoadjuvante, né? Ele é o principal investigador de um trial que está avaliando isso, e vamos ter a honra de conversar, de ter uma palestra dele sobre esse tema. O professor Henrique Kuerer é Professor of Surgery and Executive Director of Breast Programs at the University of Texas MD Anderson Cancer Center. Professor Henrique Kuerer, it's a great honor for us to have you here. Thank you so much for sharing your time with us. And I'm explaining for the people that are listening to us that you are going to speak about a topic that's very particular for us breast surgeons, because it can change what we can do in the future. So, Professor, you have your time for your lecture. Thank you very much. And after your lecture, we'll open for the audience to make some questions and to make some discussion with us. Thank you so much.
Thank you, Hélio. And thank you, João, for this opportunity to speak with you. As you can probably tell, I'm speaking with you from my hallway here in Houston in my house, which is kind of strange. I'd rather be in Brazil, but I'm excited to talk to you a little bit. And I think maybe this program will be a total an hour, but I'm going to try and limit my speaking for 40 minutes or so that we can have discussion about this. I think obviously all of you know that neoadjuvant chemotherapy has been used for a long time, and we've known that patients can have a very dramatic response. Just in case there's any residents in the audience, trainees, you know, this concept of breast conserving therapy or lumpectomy is only 100 years old or so, and it was first described about 100 years ago by Keynes, who happens to be a surgeon in London. And what they did is cut out what they could feel and put in radium seeds. Over the next 75 years, there were so many trials, similar to what we're you have to start somewhere. These are kind of called phase 2 studies. They're not randomized, but they're kind of conceptual. You can see that the local recurrence rates in those days were pretty high compared to what we would have now. I will tell you, right in the middle is Ramsdahl, 1983. So 40 years ago at MD Anderson, they allowed breast conserving therapy for stage 1 breast cancer, and a 7% local recurrence rate at 10 years was very acceptable. Now I'm bringing you now to these classic landmark randomized trial that were designed to test the standard of mastectomy compared with lumpectomy. Several things I want to mention. Number one, it's interesting, survival was the same in these arms of the trial, but the local recurrence rates were in fact higher. And that was acceptable at the time, that if you could keep your breast and keep the patient whole, that might be okay. But more important, I want to remind you that all of these trials began and were completed before we even had screening mammography or imaging of the breast. Okay, so the results were this good with just removing what we could feel or the patient palpated. Additionally, these pathologists had no standards of margins at that time. Again, still these trials, rudimentary, showed the efficacy and the safety of breast conserving therapy. This is now from a patient who, when I was a fellow a long time ago, 22, 3 years ago, there were these dramatic patients. We called them exceptional responders. She had ER-negative tumor. We had these dramatic responses, and we started to do more and more breast-conserving therapy in these cases, less surgery in the lymph nodes too. But it really had planted the seed for us to say, well, if so many patients, there's no cancer left at all, can't we figure out a way that maybe they don't even need the surgery? We found out from randomized trials at MD Anderson that obviously giving chemo for size tumors before or after, if we gave it before, we could reduce the volume of resection. So ultimately, we really wanted to get to, could we actually do no surgery? I want to remind everyone in the audience again, when we're thinking about these clinical trials to determine, for example, could we biopsy with image guidance to say if the patient had residual disease or not, maybe to avoid surgery, we're looking at this false negative result. That is, how often will we stick a needle in the patient and we're wrong when we go to surgery? But I tell you, I've been doing breast-conserving therapy after neoadjuvant for over 20 years, and I can assure you that I am leaving disease in the patient because we only remove what is an abnormality on imaging. I never remove, and we don't do that at Anderson, the whole volume, what they presented with. So when thinking about our false negative rates with this new concept of no surgery, think back that surgery is not perfect either. Of course, now we know that 50% of the cases with triple negative and HER2 positive disease are the ones with the most likelihood of having a response. We also know clearly that not only is survival improved when there's a pathologic complete response, but the local recurrence rates in very aggressive HER2 positives and triple negatives are significantly lower as well. So that's why we chose these patients to study first this concept. And I, again, have given this lecture so many times to many surgeon groups, and they say, why not leave it alone? You know, the local recurrence rates are good, the patients are keeping their breast. Why potentially harm the patients? But that is exactly what they said when every patient was getting mastectomy. And I can tell you, there's a lot of anger among surgeons about this. And probably as controversial as the idea of a lumpectomy was 30 or 40 years ago. Certainly, if 50% of the cases have nothing left in the breast and lymph nodes, we need to figure out a way to find out which are those patients. I don't have to tell surgeons in the audience that there are complications with surgery, and you know all of them, and maybe we could avoid some of them. This is at a time, of course, as we are developing oncoplastic breast surgery more and more and more. So I think there will be eventually patients who will benefit from the surgery, not just for the cancer, but perhaps for oncoplastic reasons, symmetry and things like that. But there will also be patients who will refuse the surgery based on our clinical trials if it proves to be a safe approach. Now, this idea of doing no surgery is not new. What I can tell you is that 35 years ago, medical oncologists would see patients with, the tumors going away with chemo, and they said, well, why not just give radiation? So they have tried it. The local recurrence rates, as you can see, sometimes were similar if they had the surgery, but mostly very high, and there were problems. So this never really got off. Some of the earlier good studies were done in London at the Royal Marsden Hospital, and as I'll show you, we've collaborated with them. We presented it at San Antonio, and we think there is a path forward perhaps to do it again, as I'll show you. The main problems were they didn't really use adequate breast imaging to select the patients. And certainly the patient with an ER-positive tumor is much less likely to have nothing left. The triple negatives and the HER2 are the best potential cases. We also know that MRI is great for detection of residual disease, but it is inaccurate and it does not have sufficient sensitivity or specificity. And let me tell to you like this. If we have 50% of the time patients have no residual with triple negative and HER2 positive, the radiologic imaging of complete response, that is nothing on MRI, ultrasound, and mammogram, is only 20%. So the imaging not only underestimates potentially, but quite often overestimates disease. Can we get better imaging? Might there come something? Absolutely, but we're not there now. So I don't have to tell you, how we are trying to move forward with this is with stereotactic vacuum-assisted core biopsies of these patients after the chemo. Why I show this again is for the people who are trainees. It was 35 years ago, and even in my residency for surgery, every patient still, mostly every patient came in with a lump in the breast. If we did a fine needle aspiration and it wasn't a cyst, they went to surgery. So the concept of stereotactic biopsy was image dependent on mammography, obviously, but it was developed to select patients who needed the surgery for malignant disease, so that all of those other benign ones, which were sometimes as, 90, 95%, depending on the patient population, the patient didn't need a surgery. So it's conceptually the same. Why can't we do this with neoadjuvant therapy? In fact, that was the trial that we did, a very small trial to say that maybe we could accurately identify these cases. And the concept is easy, Essentially, the hypothesis is that we can do core needle biopsies, vacuum assisted, and remove adequate tissue sampling to select cases where there really was a pathologic complete response, just like there is in this case here. I show this only in case there's not, for non-radiologists. I'll just be politically correct and say, a lot of people who read our studies, reviewers will say, oh my God, you're taking 15, 20, sticking the patient 15, 20 times? No. Vacuum-assisted core biopsy, you put it in once, you gently move it around, and you can remove successive multiple cores with just one stick. So it's not multiple sticks for the patient. That's something to think about. Okay, in our study, it was very small, but it was powered correctly. We only had 40 cases of triple negative and HER2 positive. We allowed partial and complete response. We had a very large biopsy, 9 gauge, not very, but large enough. We had to ensure that the clip was removed, and we replaced it because we were going to operate on these patients so we can figure out the false negative rate. So we just wanted to compare the biopsy to what the surgery was like. I put this as a reminder that just like performing breast conserving therapy for non-palpable image detected cancers, it is a highly technical thing, and we must be stringent with our selection. But key among this is exquisite breast imaging and biopsy. And this is led by my co-leaders of this in breast imaging. It's essential that we work really closely with the breast imagers because that is their expertise. Like you already would have known, the complete pathologic response was about 50% in these cases on this initial small feasibility trial. I tell you that we don't want in situ disease as well, this definition of PCR for us here is that we don't want to leave any nidus like the DCIS in the patients. So in this definition, we say no invasive or in situ. The number of vacuum-assisted core biopsies, median was 12 in this study. And as you can see, these were relatively small tumors, right? Triple negative, HER2 positive, the median initial size was 3, final size was around 1 centimeter. This is a complicated table, and it has a lot of numbers, but it gives us the performance characteristics of the biopsy for the patient here. So essentially, the accuracy was 98%. On the core biopsy, we missed 2 patients. I'll tell you about them. FNA was not good, image-guided FNA. It was essentially a false negative rate of half, so you could have flipped a coin with that. But the negative predictive value, that is, how often will the results predict that there's no tumor, was very high at 95%. We reviewed these 2 cases where we missed it. The first one, and this is a common problem with the other trials I'll review briefly for you, is that we didn't do enough cores. We didn't sample them enough. The first one we took 6 cores. The second case, we only took 4 cores. I can tell you that there was very tiny bit of residual disease, 1 to 3% of what we call tumor cellularity, identified by the pathologist. But more importantly, on the second case, and this was not reported in the paper, the pathologists, when we look at cores, the pathologist looks at cores, they, essentially do 1 or 2 cores of it and say cancer, no cancer, or make a diagnosis from 1 or 2 sections, hematoxylin innocent sections. We were able, by sectioning, remember this, a pretty lot of tissue, I'll show you what it looks like. They sectioned through and they were able to find cancer in that second case. So in our clinical trial, they have to submit all the tissue to ensure that we actually are not missing the cancer in the image-guided cores. I mentioned this thing about DCIS because you think that DCIS doesn't respond to chemo. It does. When we have invasive triple negative with DCIS, we convert from having DCIS to no DCIS in 45% of the time. When there's microcalcifications in DCIS initially, the pathologic complete response is less when there is versus when there isn't DCIS. But still, as you can see, about 30%, even if they had DCIS in the triple negative, are not going to have anything left. This is a good image for everyone to take a look. If you look on your right side of the screen, you can see there's about 20 cores taken of these microcalcifications after chemo. You can get an idea, a lot of surgeons will say, well, you're removing so much on the core. Actually, look how much was removed. You can see the little tiny air from the biopsy over there. The key here was that the radiologist completely sampled the microcalcs. You can see on the left, the tumor over here, I think it was about 3 centimeters with calcs. The mass went completely away, the calcifications remained. This patient had a PCR. Interestingly enough, for HER2 positive case, we can eradicate the DCIS in about a third, or 36%. But HER2 positive breast cancer comes with microcalcifications and DCIS double the time that triple negative cancers do. Why I'm mentioning this is it's a new field. We're thinking about things differently. It does not mean that these cases can't eventually have no surgery. It just there's less likely to have nothing left. But still a third of the cases will, even in that scenario. I want to briefly go over some of the San Antonio oral presentations regarding this idea of the accuracy of biopsy to predict residual disease. These were the cornerstone studies that would say maybe we someday could do this with patients. And some of the results were pretty disturbing, but I can tell you there were some significant problems with how they were designed and analyzed. So our NRG study, which is cooperative group, again had T1 to T3s, they had chemo, image-guided core biopsy was done, either 4 biopsies or 6, that is with removal of the clip, and it was stopped early, around 100 patients, because it had a high false negative rate, essentially. But the main issue here, and actually the problem was the sensitivity for residual disease was only 50%. Terrible. But I think there are issues related to the design and analysis. So about a third of the cases, only 1 to 5 cores were taken, which I don't believe is enough. We've shown it in our studies and others. And the clip removed, that is the clip that was initially there with the tumor, was not removed in about 38%. So I don't know how good the sampling was in this study. And there's lots of things that remained. There were 18 cases out of the 98 that they did not predict residual disease correctly. Like, were these T3 tumors? You know, how big were they? Were these all the ones where the clip wasn't sampled? Were they multicentric disease? We have to review that before we can pass judgment on the trial. So we're excited about seeing the review by the imaging leaders of the trial and the writing of the paper to get a little bit more details about it. Another important study was from the Netherlands Cancer Institute. And in this study, again, they did sampling with ultrasound, but the design was different. So all these cases had neoadjuvant, I believe all subtypes. But after the neoadjuvant, they had to have an MRI. And the MRI had to show a complete response or partial. The problem was they didn't necessarily have to have an ultrasound or a mammogram, and the sampling, as you can see, was done in the operating room with ultrasound only. So we don't believe that's an optimal method for detection of residual disease. They also did cores that are smaller, 14 gauge versus then our larger vacuum. And the false negative rates were very high, 37%, unacceptable, not ready for clinical practice. So some of the main issues and concerns I've already mentioned. How often did they remove the clip? Did they know they sampled the right area? Calcifications, did they sample that? How many actually biopsies did they do? So we wait the publication of this important paper again, but we'll read it carefully and see if we would have changed anything. There is also by Professor George Hélio from Germany, did a multi-center trial, a very large trial of, as you can see, I'm embarrassed, I can't add up. Oh, there it is, 398 patients. Very large study. And as you can see, unfortunately, when they looked at all the cases, all subtypes, by the way, false negative rate was almost 18%. Again, not ready for clinical practice at that high a level. But there was no standardization on the type of imaging or the sampling of the specimen or the pathologic processing. So when they did some exploratory analysis of this prospective trial, by the way, it was published either this month or actually last month in Annals of Surgery. Take a look at it. They had some explorations. False negative rate was 6% when there was a complete radiologic response. And when they used very large needles, the false negative rate was 0%. So they concluded that refinements and optimizing patient selection might be make this an acceptable method to potentially safely select patients for just radiation. I can also tell you that my colleagues in the Netherlands Cancer Institute also feel that there still may be hope with this. So although it seemed very negative when they presented it, I think that there is still potential. Finally, we combined our results with the Royal Marsden and the Seoul National University Hospital. This paper is impressed in a prominent journal, as well as should be published in the next few weeks. And again, there was no standardization between the different hospitals on what type of patients, the size of the cancers to be selected, the type of biopsy, and the imaging requirements. But as you can tell, it was exactly the same false negative rate, 18.7%, just like the German. In the planned subgroup analysis, which excluded the lobular cancers and only allowed residual imaging abnormalities to be 2 centimeters or smaller and greater than 6 samples, that is cores, they were able to reduce the false negative rate down into an acceptable range of about 3%. This brings up the idea of, what is the false negative rate that would be safe for a patient who's going to be receiving radiotherapy? I think it doesn't have to be 0, because as I told you at the beginning, I think that we leave small amounts of residual disease when we do standard breast conserving surgery after chemo too. So our MD Anderson multi-center trial, actually, where we are not doing the surgery in selected patients, is open, and we're about 75% done with accrual of this first cohort. This study we call it cohort A. It gets complicated, but I'll explain why at the end. Less than 5 centimeter tumors at the beginning, triple negative, HER2 positive. We need a minimum of 12 vacuum-assisted cores. Patients may not participate if they have diffuse calcification or lesions all over the breast. They have to be less than 2 centimeters. No residual disease, radiotherapy. Residual disease, obviously standard surgery. We follow them closely at 6 months. Our first patient is now 3 years out. We have very strong or specific stopping rules for this study. We're following these patients very closely, and essentially, if 1 or 2 patients have a recurrence in this short time frame, less than 5 years, we will stop the trial. But as you can tell, we've had a large number of patients accrued, and thank goodness, no recurrences yet. We're looking at other things. Can we use circulating tumor cells? We're looking at the quality of life of the patients. Did they say they're happy with their choice? Are they too nervous that they didn't have the surgery? Cost, cosmetic deformity, and all those things. I mentioned to you the importance of the technicality of this and your pathologist and your radiologist ensuring that everything is sectioned so you can see, so you don't miss the cancer. We have specificity in these slides, as you can read right here. Very extensive slides of these tissues to make sure we're not missing any to select the correct patients. I mentioned we're doing pretty well, 74% accrual so far. Early quality of life, we have lots of quality of life data. I just picked one that I liked the results from. 100% of the participants at 1 year either agree or strongly agree that they would decide to do this again if given the chance, that is, no surgery. And finally, what are we doing with the lymph nodes? If we're not operating on the breast, essentially, if you present with a triple negative or HER2 new positive case, less than 5 centimeters, Anderson we do ultrasound of the nodes every case. If there's nothing at the beginning and you have a PCR at the end, you have 100% chance that there's nothing left in your lymph nodes. So that's easy. We don't do any biopsies, sentinel or anything in those cases with no initial ultrasound positive nodes. When there is a biopsy confirmed node, that is N1, 1, 2, or 3 lymph nodes, we still have a conversion of about 90% of those cases. So our patient advocates and other surgeons in my group felt that patients, if there's nothing left in the breast, they might want to avoid the breast surgery still, give them this targeted dissection for those select patients who had node-positive breast cancer. And there are 6 patients in our study, actually all of them who had PCR in breast and nodes, who did actually biopsy the breast, and then we made another incision to check if there was anything left in that lymph node with the clip and the sentinel. I might also say that this study from MD Anderson was replicated. That is, how often, if we have a PCR and triple negative and HER2 positives, will we have no residual disease in the nodes when you present with a clinical node negative, that is just by exam, not necessarily ultrasound? 1.6% of patients will have residual disease, which is less than our false negative rate for sentinel. So again, I think this is going to be safe, and you'll see more clinical trials coming up to test that hypothesis. We just feel comfortable with targeted Axiory dissection, which essentially means if we biopsy node at the beginning and it's positive, we like to remove that with any other sentinels. Usually 75% of the time it's the same sentinel, but 25% it's additional nodes. So that's what we do at Anderson, in case you're wondering about the nodes. It's very accurate in our hands, the procedure. Now, as I wind down with this talk, I've spoke fast. I'm very proud of myself because there was a lot of things in this that I brought up. I go to surgeons, I give lectures to surgery, and almost always in the crowd, they're saying, well, patients like the surgery. They don't want to do the radiation. Why not just skip the surgery? And I'm like, yeah, I'm fine with it. But I just cannot explain to you what a huge challenge and effort it was for me to convince my colleagues, not just radiation, not just medical, but my surgery colleagues, to say, can we even try to do, do a biopsy and just radiate? So that was one concept. The concept, at least 6-7 years ago, when I was starting to think about it with my colleagues, of avoiding radiation completely, our radiation oncologists, God bless them, they would never, ever agree to this. It was just couldn't happen. But things change. And we had a new radiation oncologist named Melissa Mitchell, who was at the middle of her career, and she had already come up with this concept of let's just do the chemo for less than 5-centimeter tumors, and if there's nothing left, why are we radiating? We've already proven that it's killed tumor masses, lymph nodes. So this trial is now, we have another cohort C, where this trial is open now, accruing. And some patients actually want the surgery. I can tell you, in 3 years, it was not easy to accrue 37 patients because it's something new. And most of the time, the patients just felt more comfortable having the surgery because it was unknown. So this is, again, a small study, but it's the beginnings of potential to what we call de-escalation. So less surgery, less chemo for the patients, potentially less radiation. So in conclusion, I think we have to be open. there's constant change in our field. A lot of it is due to different, better systemic therapies. But as I've shown you, starting with breast-conserving therapy now, only 100 years now of being tested, we've learned a lot. We've learned a lot about imaging. We've learned about processing of tissue. Now we have very strong oncoplastic surgery. We have everything is changing. Despite this, there will remain a group of patients where 50% of the time there's no disease. So I think it is our obligation to figure out a way to identify these patients and test the hypothesis, that is, ensure safety and efficacy with clinical trials for those patients. I believe the targeted imaging and good selection can accurately identify the patients without residual disease. I want to tell you, mostly because all of you are in Brazil, and I know that in a positive way, Brazil has always been on the cutting edge of new things and wanting to do things and improve things for patients. I know I lived through it with Sentinel with all of you. I lived through it with the neoadjuvant therapy. But I think we really cannot offer this, that is, no surgery for the patients, until we have some good preliminary results that show it's going to be safe. And it's not just safe in a clinical trial. You know, we have to really work closely with the radiation, the surgeons, the imaging, and the pathologists. So I can tell you, and I'm sure you have patients that for some reason they never got the radiation, or for some reason they didn't get the surgery, and that they can do well. But I don't think that this concept is something that we could say, make this a standard. It's not, I don't think. It's absolutely not. I think it would be dangerous if you offered this to patients without us having more data to say that it may be safe. So with that, this will end the presentation, and I would love to take any questions from the moderators or any of you through chat.
Perfect, Professor Kuerer. It was such an amazing lecture. Thank you so much for sharing with us your knowledge. And in the end, you were perfect with your discourse. We should not make this outside a clinical trial. Maybe in the future we'll have good news, and things seems that we are going to choose the best patient for not make a surgery. I have just two questions for you. The first one, I have a doubt about the complaints of the patient about the core biopsy. 25 specimens. What about the pain? You make it that with local anesthesia, or make some different kind of anesthesia? And another question that I have, if you have some preliminary data about circulating tumor cells, and maybe in the future this can make a substitution for the biopsy. Yeah.
So yeah, I agree with you. Yes, we routinely use local anesthetic, and the biopsy can be uncomfortable, but usually is not, with good infiltration. I get it. Want to take the patient to surgery, you're taking, most of the time you don't have to do 20, but we need, in our trial, you have to have at least.
Yeah, for sure. Yes.
And actually it is, I know for the first cases, it's more or less, 12 or 13 on the median of it. But I hear you. It can be done as an outpatient. Usually it is not as painful. There is generally not as much scar. For benign disease, for radial scar, they have to sample a very large amount on those as well. I think the minimum is like 25. It's crazy, but if does prevent a surgery for benign disease in that situation. Yes, we are all, and now the question about circulating tumor cells. I wish there was a magic about the circulating tumor cells. I will give you some preliminary data, very preliminary, but anecdotal, they call it. We also are measuring, Dr. Lucci, Anthony Lucci from my hospital has a lab, and he's looking at the circulating DNA and the tumor cells. And interestingly enough, there were a few cases where there was a complete pathologic response. Remember, we have patients who have residual and don't have. So we have cases where they had no residual and there was circulating tumor cells, right? We kind of know that, right? Because some patients still die of breast cancer when there's nothing left in their breast and nodes. It's rare. But fascinatingly, we do 6 months and then 12 months afterwards, we have a couple of cases that went to 0 and stayed at 0. I don't remember if they were ER positive or not. I don't remember. And we have had some that has gone up and then gone down to 0, which I think is really interesting.
Yeah,
so
sure.
I do think we will eventually find something we can measure in the serum of patients or saliva or something that can assist us with this, but it's not. I think it's more, kind of like academic question rather than it's going to help the patient.
Basically, yeah, perfect. Thank you very much, Professor. João?
Yes, first of all, thank you so much, Professor Kuerer. It was an amazing talk. I totally bought your idea. And at the same time, I must congratulate you because it takes a lot of nerve to do this kind of trial. At the same time that I feel that you are in a good direction to select patients that really don't benefit from surgery, but at the same time, I feel that you are skating on thin ice because medical oncologists now are asking surgeons to look further and further for residual disease because it changes treatment and changes outcomes.
Right.
And I was quite surprised. I don't know if I got it correctly, but did you mention that only one recurrence in 5 years would make the trial stop? I mean, that seems to be quite dangerous because it is the biology of the patient, the biology of the disease that you selected are tumors that usually they relapse quite early. Yeah. And another thing that I want you to comment is if there is any cutoff age, a minimum. What about age? Is this a criteria for exclusion? I mean, yes. Young people could also join the trial.
Thank you for that, very important question. So I'll start with age because that's easy. We know that the patients less than 40 have a much higher local recurrence rate. So the biostatistics people, they came out with what would be acceptable to us, and essentially 3 to 5% in 5 years. But the way that the clinical trial works is, we don't get the results of recurrence just happen at 5 years. So we have this thing called stopping. So obviously within the first year, after 2 imaging, if we had 1 patient, the risk of having other patients is so high. So the more patients we have and the longer time follow-up, I think as long as we can accrue the total number of patients before there's a recurrence, then it's okay. Then because primary is safety. But the more salient and challenging question has to do with the benefit of adjuvant therapy after neoadjuvant therapy if there's residual disease. And this has caused a great deal of anxiety and concern among surgeons and medical oncologists. And I can tell you, we worked for several weeks to figure out, well, really, what is the risk? Let's take the example of a HER2-positive breast cancer, of who we know can benefit if there's any residual disease with TDM1, right? So we had to be very sophisticated. I work with Vicente Valero, a medical oncologist, my colleague Ben Smith, and we looked at the data very carefully to think, well, what's the real risk? So, and I'm just going to give you a little painting of it. So of those cases, so we have 1,000 patients, for example, 600 of them are going to have a PCR. So they're not going to benefit, right? Of those 400 remaining patients who have some residual disease, on average, we will miss 5 out of 100, potentially. However, all of those cases will have an RCB, residual cancer burden, of 1. So for the HER2-positive cases, the 10-year distant disease-free survival for RCB1 is around 85%, 85%. So obviously, we cannot benefit all of those 20 patients, right? Because that we might have missed, because they would have already had a 100% disease-free survival, right? So the numbers get smaller and smaller. And ultimately, even if we had a 10% chance of missing on a biopsy, an RCB of 1, we did all the statistics. We would potentially undertreat 5 to 10 patients out of 1,000. But remember, TDM1 is not 100% increasing the survival, is it really? No. There's no real drug that I know of is an absolute 100%, right? So ultimately, it's unlikely that we would benefit. We would miss a benefit, a very small number of patients. But that is an important point. So we discussed this with, there's ethics involved with this. With an IRB, this is low risk to the patient, but we mentioned in the consent. But we also mentioned in the consent that surgery, like I told you, can miss a small amount of disease too. And guess what? The pathologist can miss the disease too, depending how much they look for it when we do the lumpectomies. So in all honesty, and not global for the patient, we have to look at all of the scenarios. You could tell I have passion for this. I don't know if it's going to work, but I can tell you at every 6 months, when I get the reports, I feel sick. I'm so nervous, on the patients, because we're real-time monitoring that there's going to be something, and we have had scares. There's been 2 patients where they said, they don't know, is this a scar from the thing, blah, 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 biopsy. I was very nervous. I thought, we're going to have to close the study, but so far not. So it's interesting. You can make, depending on how you look at situations, it really depends on your perspective. And I think when we're talking about something new, we really have to have a global perspective of all the possibilities.
Perfect. João, you're mute.
Sorry. Another thing that came to my mind is if this trial came good in terms of safety, and we hope it does, I also concerned about the reproducibility of this procedure, because it seems to me that you need to systematize a very thorough procedure in terms of how you select and how you sample the the patients. So, and to do it universally is not easy. I mean, you need really to have a breast center with everybody in the same page. So reproducibility is going to be another issue, isn't it?
It's a huge issue, but think about it. The same thing was for breast conserving therapy. Even 5-10 years ago in some places in the United States, they just weren't doing the right imaging. They didn't sample. I think it's no excuse that you don't have excellence with your standards, right? So we try for the best, but 30 years ago, 35 years ago, they didn't even do imaging on the randomized trials. They just said, oh, I feel something, take it out. I'm not saying we should go back, but I think we're taking this one step at a time. We don't know what's coming next. Like Elio mentioned, is there going to be something that will help us select better? Is there going to be another imaging that's even better than the biopsy? And just like breast conserving therapy for surgery, if you can't biopsy by MRI, your center should not be doing it if you're going to do an MRI.
Absolutely.
I'm with you, Joel. I mean, you're right. It's a huge issue. I feel like I'm in a very good center where there's very close collaboration with experts in each of the disciplines, and I'm even afraid of it here. But that should not make it stop progress.
Hélio, do you like to take care of the audience?
We have some questions from the audience here, Professor. Ari, you can put the question number 1 from Francisco Pimentel. Francisco Pimentel asks, what do you think about vacuum-assisted biopsy, false negative rates on the breast, and selection of patients based on residual disease for additional adjuvant therapy? Can we miss some case?
We can miss some case, probably 5 out of 1,000, but the actual benefit to all those 5 is not going to be 100% because TDM1 is not 100%. So could it be higher, 10 out of 1,000 if we have a false negative rate? Yes. Can we miss disease with surgery? Yes. Can we miss disease with pathology processing? Yes. So it's not just the biopsy.
Perfect, Professor. I have another question here. Very interesting point of view that you told us in your lecture. It was done by Felipe Zervis. While the breast surgery is still being performed, do you think we can avoid the axillary surgery in CT1 or T2 and 0 patients with breast PCR in the triple negative and HER2 patients, as you said that you're doing in MD Anderson?
Yes, and I'm aware of some clinical trials, not my group, that are going to do that. So yes, the answer is yes. I think it makes sense because if, at least for triple negative HER2 positive, if it's less than 5 centimeters at the beginning, you have about a 1.5% chance you're going to leave residual disease in the nodes. So, it's less than sentinel node false negative, right? So yes, I think that's obvious.
Okay.
Yeah.
And do you think these patients will need axillary radiotherapy after the surgery or not treatment at all?
They probably do not need it, but I guarantee you our radiation oncologists will treat it anyway.
Okay, perfect. We have another good question here. Just a moment. From Sister Urban, our friend from Curitiba. Is some kind similar of your cohort C that you told us. What about change the questions of avoid surgery, I mean neoadjuvant therapy and oncoplasty, then in a selected group of patients, the great responders, avoid radiotherapy?
I agree, absolutely. I think that is a great potential, especially for oncoplastic with shrinkage and radiation, but we start, well, you could, the patients right now are eligible who we do oncoplastic if there's nothing left in the surgery, in the lymph nodes and the breast, and they have oncoplastic standard here, maybe 75% of breast conserving therapy. Even the smallest we do oncoplastic. Yes, we're testing, can you do it? And I'm excited about it, but those results probably won't be out for another 5 years.
Okay, perfect. Thank you, Professor. We have another question here from Henrique Lima. Great lecture. We have a lot of people saying, great lecture, thank you very much, it was amazing. A lot of people, Professor, that are thanking you about your lecture. So the next question is, have you ever considered performing a percutaneous image resection instead of a biopsy in your patients or in your trial?
Yes. I've worked with lots of different companies over the years to, different technologies. Some of them have been tested, others have not. Yes, for a long time. Yes, we have considered, yes, we tried it. I think I'm more interested in the biology kind of it than actually the actual total removal of something that was there. Yes, that might happen someday, but it's not ready now.
Perfect, Professor. I think that we have no more questions from the audience. João, you wanna?
There is one question from Darley that I think it was before that. Let me look for it.
Yeah, it's here. I found it.
Hi, my friend Darley. I know everything you're doing on Facebook.
Do you believe that molecular subtype lumina with use of hormonal therapy could be a good option to avoid surgery in selected cases?
It could be possible. Not that often, but it does happen.
Maybe for the CDK4/6.
Maybe. Yeah. Who knows what drugs are coming up?
So I think that's it. Right, João? Do you have any other comments?
What is the time frame that you expect for us to have results? And I think that this is the first step for safety. Then the plan is for
we haven't published our safety yet. So we had to first do 12 patients at 1 year, and that was the first part. So we already have that quote unquote safety. It's not that safe 1 year, but because remember they were getting trastuzumab, for 6 months. So that's done. But as soon I expect that the accrual will be completed in 6 months for the trial, and as part of the trial, we will report. I know it's small, but the first year when everyone's reached 1 year, we will give the preliminary results, and then at 3 years, the results, and then at 5 years.
Okay, yeah.
So probably a year and a half from now.
Yeah.
That's great. Right. I think, again, it's a very important trial, and I think that you're advancing knowledge in a very risky area, but we're glad that there are people that can do that with an organized team. So thank you very much. That's really nice.
Yes. It was such a pleasure and such an honor for us, Professor Kuerer. Thank you so much for your time, for sharing with us your knowledge. And we hope to see you in Brazil, maybe next year when everything finishes.
I hope so too. Hopefully it will be on the beach in Rio.
Yeah, for sure.
I believe that you have another meeting here in November, the Breast MIT, I think.
Yes.
That would be very nice. We'll be looking forward to that. Thank you so much for taking your time. Take care.
Take care. Be well. Thanks.
And thank you. Thank you so much.
Bye-bye.
Thank you, Professor. Bye-bye, Professor.